Good afternoon. 4:29 and 40 seconds. So we can start in another 10 seconds. Welcome you all. We are discussing a subject which is challenging, definitely challenging, and will always remain challenging because it's a condition where you can never offer perfect results. You have to meet the expectations to the best of your ability and struggle all the while to get better and better. And nobody can say that he's learned ptosis surgery ever, congenital ptosis in particular. Acquired is also challenging, no question about that, but congenital specifically. First, we start with show of hands. How many of you, Shilpa says that nobody in this audience needs this course. They all do it better than us. So how many of you are all doing it your own self, this? So almost 75% of the audience. So then we will be discussing the basics as well as the challenging aspects, the things that we have learned with a lot of mistakes and continue to make those mistakes to try and get better. So we will start with the making of the right decisions. Okay. So making the right decisions, which will imply how do you evaluate and choose the right procedure. And that right procedure will be different for different surgeons. And this approach we will see when different surgeons speak. Then we'll talk about mild ptosis. Of course, there are any number of approaches for mild ptosis as well, but we'll have the Fasanella servet covered by Jayant. Then Tarjini will tell us for possibly the most commonly done procedure for congenital ptosis, the levator resection. And then for the cases with poorer levator function, the frontalis sling procedure will be covered by Dr. Mukesh Sharma. I'll cover the difficult situations of jaw winking, blepharophimosis syndrome, and ocular motility difficulties. And Shalu will take up the most difficult area, that of managing the complications. And we'll have a discussion. We will have the discussion with each presentation for a couple of minutes so that we don't run short of time. If the talk finishes in 8 minutes, then we'll have 4 minutes for discussion. If it finishes in 10, we'll have 2 minutes for discussion. So let's start with Shilpa. Shilpa is ready.
Hello, am I audible?
So Shilpa is an oculoplastics trained person from several institutions, excellent surgeon, and we look forward to hearing her on choosing the right approach and the right decision making.
So good afternoon everyone. I feel half of the audience doesn't need this course actually. So why is it important to make the right decision in congenital ptosis? Although it presents very early in life, but it's not as simple as it looks. It is not just only isolated ptosis. Sometimes it might be associated with many of its association, which can be ocular as well as systemic. To decide what to do and what right approach to be made, we must always start with a proper evaluation of the patient, and for which history taking is the most important part. Asking for diurnal variation, not to forget about ocular myasthenia gravis in children, and any movement of the lid on opening the mouth or on eating. Usually we can ask the mother whether the lid moves up and down on drinking milk or not. And any abnormal movement of the eyes associated with drooping of the eyes. So there are certain specific history points which we must ask from mother and parents. Next is proper evaluation of the patient. So the examination usually starts with the measurement of palpebral aperture, vertical as well as the horizontal. We all know that the margin of the upper lid to the margin of the lower lid is the vertical, and the difference, this distance between the two medial and the lateral cantha is the horizontal palpebral aperture. It holds importance in several ocular and systemic association which are associated with congenital ptosis and will be spoken about by further speakers. Further, we must check for the amount of ptosis, for which we must measure the vertical size of palpebral aperture as well as the MRD1, which is marginal reflex distance 1. MRD2 is also important, and especially in cases of squints, we must also measure the distance from the limbus to the lid margin, the lower lid margin. Next, we have to grade the ptosis whether it's mild, moderate, and severe. So if it's 2 mm or less, it's mild, 2 mm to 4 mm, it's moderate, and more than 4 mm is severe ptosis, which usually will cover the pupillary axis and would need surgery. For checking the levator action, Burke's taught us to ask the patient to look down after fixing the frontalis so that the patient doesn't use frontalis, and next ask the patient to look up and measure with a transparent ruler how much is the excursion of the upper lid. So if the lid moves more than 8 mm, it is good levator action. 5 to 7 mm is fair levator action, and less than 5 or less than 4 is poor levator action. Measure the margin crease distance, obviously important to symmetrize the surgery on the other side. Bells is very important post-operatively. The cornea should be safe, and we must check upon the Bell's phenomenon. This would usually guide us which surgery to do and how much, whether we have to undercorrect or not. Corneal sensations should be checked, and Schirmer's should be checked. After so many years also, in each and every case of ptosis, I jot down from 1 to 11 all these points, and actually they help. I feel that it is very important, and especially when you go back like 6 years, 8 years, when you see the findings, you become more clear of what you did and why you did. So you must always write all these points. So not all patients will require ptosis surgery in infancy or in the first year of life. But if the pupillary axis is not covered, then in children, like before 1 year also, you might need to do a corrective surgery. And what we need to decide basically is the age of surgery and choice of surgical procedure which we need to do for that patient. Usually it is performed, the ptosis surgery, after 3 years of age, and if we are planning to do facial aorta sling, then more than 4 years of age. If the pupil is covered, as in this child, early surgery at age of 10 to 11 months also might be needed. So if it is mild ptosis and levator action is good, more than 10 mm, and there is good lid fold, then Fasanella servate is the choice of surgery usually, which gives a very good result. The upper lid fullness is also good with Fasanella servate for mild ptosis patients. For moderate to severe ptosis, and if levator action is more than 4, equal to 4 also, I have tried levator resection. Although it's very difficult, you have to go literally very high up, but it works well. And for severe ptosis with poor levator action, 4 mm or less, there is no other choice but to do frontalis sling, and facial aorta, if you are doing bilateral surgery, is the material of choice. The congenital ptosis, as we have spoken about this, that there are many associations. You must always check for ocular motility. The extraocular motility examination is equally important. Bell's also depends upon this. Along with the LPS weakness, superior rectus usually is involved with this, being the partner of crime. So superior rectus weakness should be checked, and double elevator palsy should be checked. As in this patient, she has ptosis and with double elevator palsy. We must always improve the ocular motility and do squint surgery before attempting ptosis, because we need to improve the position of the affected eye in primary gaze, which would decide the symmetry of both the eyes. And we want to relieve the poor Bell's phenomenon, which happens because of poor superior rectus or double elevator palsy. And we need to correct the pseudotosis for the patient. Blepharophimosis, as we all are well aware of, we must ask history of ptosis and similar complaints in other people of the family. For this syndrome, we operate in 2 stages. Stage 1 is we need to do the epicanthal fold creation. correction of telecanthus, and increasing the horizontal palpebral aperture, which can be done by lateral canthoplasty. And stage 2, we correct the ptosis finally, and bilateral facial lateral sling is the method of choice. For Marcus gun, we need to correct ptosis. Elimination of jaw winking is the aim along with it. But with that, we have to ensure that maximum possible symmetry is there. So as in this lady, almost 95% of Marcus gun has been eliminated, although I have only done unilateral surgery for this. So bilateral levator excision with bilateral facial lateral sling is the method of choice, but I have done unilateral surgery in this lady, and she has had good results with it. So there are situations in ptosis when the decision making is not that easy, what to do. As in this 11-year-old girl, she has severe ptosis. Ptosis surgery must be done. She has had 2 squint surgeries done by a pediatric ophthalmologist. Still, you will see at the end, the ocular motility in this eye has not improved. When she looks up, the right eye goes down actually. So even if we plan undercorrected sling surgery, it is not going to help and the cornea is going to go bad. So I have just, and thankfully with God's grace, see the internal pterygoids help her so much. So in this picture you can see that internal pterygoids are actually opening the lid. I have not done anything for this patient. I have just left her so that she can visit Dr. Grover later. And so the choice of procedure majorly depends upon degree of ptosis and levator function. Surgeon preference and resource availability might play a role. In spite of all the decision making and making the rightest of choices, recurrence necessitating more than one operation is not uncommon for these patients. That's what makes the making the right decision challenging. Thank you, all of you.
Thank you, Shilpa, for really summarizing it very, very well. There are a couple of questions that I will ask the experienced surgeons here so that it is for everybody to discuss and understand. One is that we do early surgery for those with severe unilateral ptosis. And how early is that early? Tarjini? Can you have the mic, one mic for the... yeah, we are discussing a situation where visual access is at least partially covered.
Right. So in that situation, I go by the milestones. So when the child starts having neck holding, maybe about 3 to 4 months to 6 months is when I would like to perform a ptosis surgery. The only exception there is if it is a Marcus gun with severe ptosis, because with the feeding itself, you know, the eye keeps, and a severe Marcus gun, the eye keeps opening up, so you're not really worried about amblyopia.
Okay, the second question is, we know that the bilateral ptosis in blepharophimosis syndrome has also now been shown to be amblyogenic. So are there situations where you have operated on blepharophimosis syndrome early to prevent amblyopia?
I had done a study where the cause of amblyopia in blepharophimosis is not only the visual deprivation, but also because they have a thick, small phimotic lid, there's high incidence of astigmatism. So I had done a series of topographic analysis and I found that the astigmatism is so high, so that also leads to some amount of anisometropic amblyopia. So in this situation, like Shilpa had already managed that one can go for single stage or multi-stage, but I usually prefer single stage. I try to finish all the surgery, provided I know that there can be a follow-up losses. So those patients who comes from distance, so we had done a comparative analysis doing a multi-stage and a single stage. In the single stage, I had done all the epicanthus inversus and the lateral canthoplasty along with the ptosis correction, and in the multi-stage, first the lateral canthoplasty and epicanthus inversus, and the second stage for the ptosis. So we did not find any difference. So I feel that if one, like if you feel you can go for single stage, that is better.
And
to
what
prevent,
would be the timing when you would do this in blepharophimosis syndrome? If you were to think of early intervention to prevent amblyopia specifically, when would you like to do it?
So 3 years. If the visual axis is not covered, definitely 3 years. But if it is
No, I
covered,
think the question arises largely when most of the pupil axis is getting covered. Those with the severer ones, with the pupillary axis is largely covered. Now, there are studies which show that even a partial coverage of the pupillary area is amblyogenic. So, it's not that pupil should be totally covered. So, Fairuz, you were saying something. When would you intervene, supposing you were to intervene for blepharophimosis?
So I would intervene when the baby comes to me. Like, usually they identify around 3 to 4 months, and 3 to 4 months is when the visual development is happening in these babies. So as soon as they come, so what preferably that I do is, like, it's nothing to do with cosmesis. So the medial canthus is not addressed. The only addressing of the situation is to clear the visual axis. So
how
it's
many
just
would you have done at an early age of 3, 4, 6 months? In
till
blepharophimosis bilateral.
blepharophimosis bilateral, maybe more than 15 so far.
And what do you do? Use silastic?
So I use actually an ethibond suture, which is like 30 or 20, just to lift the eyelid. And
Why would you prefer that rather than a silastic?
Because the child is going, it's not that, like, that is the right way of doing, because I know it's a temporary procedure, because the baby has to undergo a repeat procedure when the baby grows up, like maybe 3 years or 4 years. So this is like just a temporary thread or something which has to lift the eyelid for the visual development. And then I tell the parents that this is going to be repeated when the baby is 3 or 4 years for the medial canthoplasty and the ptosis.
Okay, we'll have some more questions, but we'll address them with individual surgery. Like in levator, there are people who say that it should be done earlier. Now there are studies which say that.
So what is your youngest age?
I would normally do it at 3 months. For the unilateral ones, I've done it at 3 months.
Yes, sir.
For bilateral one, I've only done one, and that was at
One.
the age of 1 year when he presented.
Okay.
So just a quick point while Dr. Jayanta loads his presentation. This is one point which I learned actually from Dr. Honavar, that in blepharophimosis, the whole palpebral fissure moves upwards. So don't go by the PFH, because even the lower lid is high riding. So actually the pupil might be exposed, and in those situations I do not operate. So I don't go by the PFH, I go by actually whether the pupil is clear or not.
Absolutely. Jayant will tell us about managing the mild ptosis.
Respected Kumar sir and all the audience. So, in the fascicular surface is a choice of is a very easy process mentioned in the book, and of course in pediatric it's very difficult. The reason is that in old age we can do all Shilpa already mentioned, we can go for a Simon's test, etc. We can assess the bells, but in case of a pediatric, as our course is on pediatric, is little difficult. Initially it was not a long back, on 1961 first. On that time, during the fasciculata survey, it also include the levator, part of the levator. Till now, there is a lots of modification, more than 30 modification. Out of that 130 modification, one of our chief author, Dr. Grover sir, also one of the part of one modification. It was published in BJO 1983. They modified one big significant modification. Now another big modification was there is a externalization of the suture. So that is earlier it was a big challenge for everyone. So there is a exposure of the cornea. Now it's not a issue. Nowadays is not at all a issue for exposure on the cornea, because the high quality monofilament, absorbable suture, and externalization technique of the suture. Though it is mentioned as a simple procedure, that the workup should be very good. So that if the patient is prone for dry eye, any history of dry eye generally is not a good candidate. And as that previous discussion, in mild case, this is a big question. $1 million question is, in congenital, in mild, should we go for a very aggressive treatment or not? Our main aim is to prevent amblyopia. Our main aim is to prevent complication, because as we know that in pediatric age group, follow-up is a bit difficult than in adult population. So we can look at all those points, and accordingly we can do. Generally in pediatric age group, for a mild, This is not exactly a procedure of choice most of the time, because now it is today's era. But with the advancement of some more clean and under microscopic surgery, we can excise. And in the book, so many things are there. So minimal ptosis, maybe 1 to 3, all are so much of vague. Levator function 9 to 13. Okay, it should be more than 8 mm. And phenylephrine test. Another question is the phenylephrine test. Is it indicated or not? If phenylephrine is positive, is indicated, or phenylephrine test is negative, is generally indicated. There is a two schools of thought again. So some thought that if the phenylephrine test is positive, the results are good. If phenylephrine test is negative, results may not good, but you can go in both the cases, but you should do a phenylephrine test in all those cases. So, but we should know what about the contraindication. As all are big surgeons, all are good surgeons, so no need to explain each and every point. I am just critically few points I am analyzing. Those are any disease, underlying disease in the family or child, or any history of some underlying disease like those as I listed, pemphigoid, conjunctival scarring, which may lead conjunctival scarring in such cases, and the child prone from an area of trachoma. Nowadays, of course, trachoma is very, very less, well controlled, but still we can, and prone case of conjunctival granuloma. If the other eye or somewhere in other area there is a granuloma, those are a prone candidate for granuloma. We can think this is not a good at all for a, if there is. Then another big point is that Shilpa mentioned it. Of course, I am just elaborating few points. In congenital myasthenia is not a very, very rare, but we can think before touching for fascicular survey in a mild case. If it is a congenital severe ptosis, is easy to treat. We can go for a sling. If there is a moderate ptosis, we are confirmed lead crease is not there, so we can go for a safe way, we can go for LPS resection. But in minimal, there may be a crease, there may be a thing, or there may we misguide us. So myasthenia, we can exclude thoroughly myasthenia gravis before touching for mild cases in case of. So that is a tensilin is one of the tests, but unfortunately in most of the part of our country that endorphinium hydrochloride not easily available. So we are doing generally the neostigmine test. Though we are mentioning is a tensilin. For tensilin, the drug of choice is the endorphinium hydrochloride, but in most of the part, in our part basically is not available. So we are doing a neostigmine test basically. So there is some clues are there. If there is a transient some squint, if there is a transient ptosis, then we can think there is a possibility of myasthenia gravis. We can rule out. It may be a unilateral, not necessary. It may be a bilateral, it may be unilateral. So there may be so many points, and to assess the variability and fatiguability is very, very difficult in the children. So the neostigmine test or phenylephrine test may be one of the points. And another is a big challenge in the pediatric group. There may be reverse bells. For suppose all Shilpa already mentioned, in some cases there may be reverse bells. Then you should not be so much of aggressive, because it's very, very rare, incidence is very, very rare in reverse bells. So we can look all those points. Leader easily opened by examiner, and then patient, and anastosis in contralateral eyelid also one of the important point. There may be a bilateral ptosis, or we may then we misguide. If we do a one surgery, there may be droop in the other eye in case of mild cases. So you must be very sure there should not be a bilateral one. So those are the points. So natural history also, to exclude there is so many phases are there. Refractory phases, we should exclude the refractory phases. Those are the points. What are the indication actually for mild congenital ptosis is the one of the point. And next is very commonly in pediatric age group, fascicular survey are basically is a choice for us is for a residual. Suppose we are doing a LPS resection, then there is a residual ptosis. What to do? To convince for a against sling is very difficult in such cases. because of the lead lag. So in such cases, if we want to overcome all, the next is that we can go for a residual acquired ptosis, or those are the basically in post-operative ptosis. So those are the some steps already is all mentioned. Then some points are, is it required for a Fasanata, Potarman's ptosis clamp? If we do that clamp, there may be a more edema. Instead of that, we can use a 2 artery forceps also. But sutures are very, very good at less traumatic, and with a advancement of our that radio frequency knives, we can do so much of things. So I will skip that one video, time is over. So those are the some points of correction. Then again, another big question is decision amount of excision. So the simple rule of the thumb is that for, suppose you want to overcome 1, you want to correct 1 mm, you just excise 2 mm. If you want to correct 2 mm, then you can excise 4 mm. Then now again question is, if there is more than 2, generally I will not, my choice is not a Fasalata survey. If more than 2, generally I prefer less than 2, because if I excise more than 5 or 5.5, there may be other complication here, because our is not less per the Western population. Our lead tarsal plate height is as low, so that's why for us 2 mm I think is, for me at least 2 mm is the ultimate. So complications are, there may be some corneal problem, or there may be a contraction of the or there is a cicatrization of the conjunctiva, may lead later on other problems. Those are the complex. Otherwise, it's a very, very safe procedure. And the recent one is that always we can go for externalization of the suture. Both the knots should be in external side, then we can do there will be no any fear point of view for corneal exposure. But the main part is that due to the, we will excise few part of the conjunctiva, the roughening of the conjunctiva, those are not suture only, those are the points for the things, and we can go for a phenylephrine test also. Thank you.
Thank you, Jayanta. So just 2 questions to the audience, or any questions from the audience to Dr. Jayanta first.
Eyelash sign.
Eyelash sign, earlier it was there in some post-operative etc. also, but nowadays with a advancement of our excision under microscope surgeries in Fasalata, very rarely it is mentioned in the book. Basically there is some signs, those are the things are there, but with you and I just observed some Hanover one surgery also, it is uploaded in YouTube in so much meticulous excision, so hardly any. But big issue is that once we can cut the conjunctiva, that is a rough one. That rough one may create in future problem if the child is prone for, nowadays for contour is a very good surgery, but main issue is that long term we don't know, because in case of a pediatric we can think that child may face 70 years more. In case of a elderly 60 years old may survive 10 years, but in a
okay,
child
Jayanta,
it will be very
how many of you, Jayanta or others, choose Müller's muscle over Fasanella, and how many choose Fasanella as their first choice in congenital ptosis mild cases? Yes.
Yeah, so in most cases, in my hands, levator resection works very well, so I prefer that. But if I have to make a choice, I would go for Müller's muscle conjunctival resection.
How many have you done in congenital ptosis?
Probably maybe about 20-25 cases.
And quite happy with the results?
Not completely happy, and that's why the shift to levator resection, because in my hands I get more predictable results with levator resection. Like Dr. Jayanta mentioned, if it is more than 2 millimeters correction, I definitely do not keep either of these procedures in my bucket list.
Yes, anybody? Mukesh?
I do Fasanella only in most these cases, but in half of those cases where I am doing fascianella servate, I combined it with the skin muscle excision. So I make an incision on the anterior surface also. That gives me two advantage. One, you get a symmetrical lid fold. Secondly, there is some time you get a lash through. So that is also not there.
Okay,
So that's the added thing which I have started doing off late, because I find the symmetry is not similar in all cases.
Okay, 2 points that I will make. One is that I found whatever experience I had, that was some time ago, of Muller's resection. In congenital it didn't work so well, but in adults it's working beautifully, those with positive phenylephrine test, involutional ones, and that's why I stick to Muller's muscle resection largely in them. I've done a few in congenital, but largely gave it up. And fascianella I love for the predictability of it, and I'm able to get a good contour, and I find a very symmetrical lid. If the lift is the same, if it comes to the same level, the crease invariably comes to the same level. So I have not found it necessary to, if you are keeping the resection up to 4 millimeters, I don't go anywhere beyond 3.5 generally. So, and if you've left 5 millimeter tarsus, I don't get a redundant skin. I got it only in cases where early days I did a second fascianella and I left very little and I got a excess skin and I had to do a skin resection. I have not repeated the mistake. So that will happen if you're leaving too little tarsus or if you're repeating the procedure or something. So that is one situation. To me, it is a fairly predictable procedure for mild ptosis, no contour problems and no correction. Predictability over 90-95%, except in cases who get more reaction, who get more inflammatory reaction sometimes. And that was largely happening when we were using 6-0 sutures of Vicryl. Now with 8-0, I think that has virtually disappeared. So that's my experience, sir. Let's go to the...
For me, like adult
Tarjini, are you ready?
versus congenital. Adult definitely 2 millimeter less ptosis, MMCR.
Yeah.
But in case of congenital, if you need to decide between MMCR and fascianella, then I feel fascianella is a better option. But not MMCR doesn't work good in case of
to me,
congenital.
in my hands, it doesn't work.
Even
And of course, it is very difficult. Especially, I feel it's difficult to dissect that exactly. This I just faced that one. So that's fascianella is very good. But one option is that we may cut some amount of tissue. In others also, we may cut.
what is
That is-
chicken fascianella? Have you tried chicken fascianella ever?
No, well,
Sir, have you tried? They say that if it is beyond 3 millimeter, then you should do a chicken fascianella. Chicken fascianella is something like you do excise the tarsus. Normally we excise max 3 millimeter. You can go around 4 to 5 millimeter, and along with some amount of plication of LPS.
Okay, let's have
Thank you.
Tarjini discuss the commonest procedure, the gold standard procedure, levator resection.
Thank you very much, Dr. Grover, for having me as a part of this course. And I'll be discussing levator resection in congenital ptosis. This is my procedure of choice for most patients who have levator action of say about 3 to 4 or more. I just wanted to start with this one series of pictures of the same child with right eye ptosis. When he presented to us, he was about 3 months of age. You see on the extreme left-hand side panel there. And as you see, we operated him because the visual axis was obscured, and this is a levator resection I have done. Now in a small child, when you can't assess the levator function, the one clue that I go by is the presence of a lid crease. So even if I see a faint lid crease, that does suggest some amount of function in the levator. And this is a levator resection at about 6 weeks post-op. This is about 9 months
What is the age
post-op.
of this child?
This child was about 4 months old when we operated him. And this is 1 year post-op picture, and then that's 2nd year post-op, 3rd year post-op, and 4th year when you start noticing the droop in the upper eyelid.
Later.
So at that point of time, we decided to go ahead, and then I did a
Sling later.
sling at that point of time for this child. And just to show you, so this was at presentation, this was after the levator resection.
Then he had a droop when he was about 4 years of age, and then we had to do a sling. And if you notice over here, the sling works well when he uses his frontalis. Look at the brow elevation. But when he's not using his frontalis, you see a little bit of droop in the sling, which is what you don't see when you do a levator resection, because the frontalis is not involved in that surgery. This is just to give a broad idea of the life that
Excellent
levator resection.
documentation.
Yeah, thank you. So in my mind, the advantages that levator resection has is, one, it allows you to have a good correction of ptosis even when your levator action is poor. This child has 4 millimeters of levator action. You don't have too much of down gaze, lid lag or lag ophthalmos. There is an opportunity to give an excellent cosmetic outcome, symmetrizing the eyelid fold on both the sides. These are serial pictures where you see the lag ophthalmos as well as the down gaze lid lag reduces. This is 1 week post-op and 6 weeks post-op, where you see that it sort of tends to go towards the normal side. But like Dr. Mukesh mentioned, the best part is that you can actually adjust the eyelid fold and you can equalize the pre-tarsal show, because that is something that the patients are most concerned about. Most of these patients, rather than the droop, complain of that inequality of the pre-tarsal show that they have. And levator resection gives you an excellent opportunity to symmetrize the tarsal show on both the sides. This is a child who, this is 1 year post-op result, and you see that the eyelid height is maintained after surgery even at 1 year post-levator resection. And these are a series of, all of these are congenital ptosis, but adults, operated in adulthood. Excellent levator function, 13, 14, 15, more than 15 millimeters, and a very good result in all these patients. So these are patients where I do not opt for Mueller's muscle conjunctival resection, because in my hands, and this is a very individualistic thing, I get very good results with levator resection. I'll go to the video, but before that, also to bring out some of the disadvantages. It is not every child with congenital ptosis in whom you'll get the perfect correction. Undercorrections are known with levator resection, but then undercorrections happen with other forms of congenital ptosis surgery as well. You will also sometimes have overcorrection. It's rare, but you can have it. This is a child with Horner syndrome, where I have a little bit of overcorrection which has persisted. This child is probably 1 year post-surgery and the overcorrection still persists. I've burnt my fingers. This is a fornix prolapse, and I'll tell you why this happens in congenital levator resection, specifically congenital ptosis. It's an adult patient, but with congenital ptosis. I've had to reposition the fornix, and this is after the fornix formation suture. And there are some things which you just can't correct. Like this lady, in spite of having a decent correction, was so bothered by the lash ptosis. But these are things that are out of your control, and that's where counseling and realistic expectations sort of play a big role there. So since this is a video course, let's just move on to the video. So I'm showing you an adult patient, and the video is not running. Okay, yeah. Okay, so this is not a patient under general anesthesia. This is a patient under local anesthesia. I prefer to use prilocaine on the skin. This is a completely unedited video. It's a 10-minute duration video, so I'm going to skip through some parts. I like to mark the eyelid crease to symmetrize the pre-tarsal show on both the sides. And after my marking is done, I prefer to inject just local infiltration. And I'm very specific of few things, like using a small needle, a small gauge needle, a 1 cc syringe, reduce the pain so that you have the maximum sort of cooperation from the patient. You avoid hematomas, because color changes are very essential in getting a good outcome in congenital ptosis surgery. And if you have hematomas, it sort of changes things for you. So I don't use cold steel. I use the radiofrequency device itself for the skin incision. I've not seen excessive scarring with it. So I give the skin incision, just the skin, not the orbicularis. In the next step, I start dissecting the orbicularis. Now this is going vertically down through the entire thickness of the orbicularis. And once the complete thickness of the orbicularis is dissected, I then move my radiofrequency device at an 45-degree angle downwards towards the tarsus. So you'll start seeing that soon. You see some amount of fat infiltration. It's a congenital ptosis. There's fat everywhere in congenital ptosis, and that is what makes sort of surgery a little difficult. So this is going down to expose the superior surface of the tarsus. Now you start seeing, so this color change is very important, and that's why you don't want to have hematomas. So you're seeing the skin, the orbicularis, the upper border of the tarsus, the remaining skin and orbicularis on the other side, and in between are all your tissues of interest. Once I have separated the superior border, or I have identified the superior border of the tarsus, that's the point where I disinsert the levator from its tarsal attachment. And you see those small burns on the surface of the tarsus. Once you've disinserted the levator, you'll start seeing the vascular arcade. So I always dissect the undersurface of the levator first. And that's for a reason. That's because the vascular arcade is constant in position. There are no anatomical variations. The vascular arcade is always under the levator and above the Mueller's muscle conjunctival complex. So in your mind, there's no ambiguity as to which structure is the levator muscle. So you see the vascular arcade looping around at the upper border of the tarsus there. Once I have dissected the undersurface to a sufficient extent, and by sufficient I mean these are cases where you might need a supramaximal resection. So I stop at a point where I start seeing criss-cross fibers under the levator. Those are the phonacial fibers of the levator, and if you dissect those, you're likely to see fornix prolapse postoperatively. Then I hold the levator with a forceps and separate it from the skin and the orbicularis on the other side, as you're seeing over here. So this is the superior lip of the incision, and now the levator muscle, septum, fat complex is being dissected off from the levator. In congenital ptosis, you do see fat infiltration within the muscle, and it is extremely important to identify whether it is fat infiltration within the muscle or is it the preaponeurotic fat pad. So a little pressure on the globe sort of pops the preaponeurotic fat pad out like a nice, it comes out, it has a very popcorny sort of a feel. And once you have the levator identified, then you go ahead and do a resection of the levator. I prefer to always overcorrect congenital ptosis, because with over a period of time, undercorrections are very common. If your patient is an adult and under local anesthesia, this becomes easier. If your patient is under general anesthesia, intraoperative assessment and where you leave the eyelid is a very complex sort of a thing which is very individual to each surgeon. I take 3 sets of Prolene sutures, and I pass 3 Prolene sutures to give me an adequate height as well as contour to the eyelid. You see that I have opted for a little bit of overcorrection here. The lid is just at the superior limbus. And then I finalize all my 3 sutures once I have the adequate contour as well as height. This is, I think, a fairly routine step. Everybody does the same. It's 6-O-Prolene, which is used to anchor the levator to the tarsus, and I tie my sutures. Once this is done, I form the eyelid crease by actually taking 3 vicryl sutures from the lid, lower lip of the incision onto the stump of the levator muscle. If the stump of the levator muscle is quite thick, I debulk it, otherwise I don't. So this is the lid crease formation suture that goes from the lower lip of the incision into the levator stump. Again, 3 such sutures. I do not take the superior lip of the skin orbicularis incision in this lid crease formation suture. And after this is the routine skin closure, which I generally tend to do with a running 6-O-Prolene suture. I like to use a bandage contact lens in most of my cases, and if required, I also put a frost suture at the end of the surgery. So that's just my technique of how I do levator resection and some of the results that I have got.
Thank you, Tarjini. That was excellent. Beautiful video. We all enjoyed it. Any questions or any opinions regarding the surgery from any of the audience?
I have a question, Tarjini. Sometimes in these type of congenital ptosis, the levator is too much infiltrated with fat. So how are you absolutely sure that you're holding the levator and not something else?
That's the reason why I dissect the undersurface first. So when you are dissecting the undersurface, you have the contrast of the Mueller's muscle conjunctiva underneath, which is red in color, and you have the vascular arcade. So you're very sure that this is the undersurface of the levator. Then the confusion is when you're dissecting the oversurface. When you're dissecting the oversurface, the preseptal fat is always it's not a fibrotic pad of fat. It's very sort of, it has a very poppy feel. So you give a little tuck on the eye and it sort of pops out. So till I see that sort of fat, I keep dissecting everything anterior to it, assuming that this is the septum. And then my final confirmation is when I see the vitnals. So I stop when I start seeing the vitnals. And then whatever fat is there within that levator aponeurosis, I assume that is the
Tajani,
fat
you don't
within.
see vitnals every time, especially in those which are fatty infiltrated. You may not have a well-formed vitnal. So things are not always as well defined as that.
Right. So in most cases, in congenital ptosis, you'll see that the fat infiltration is mainly medial, in the medial half of the levator, and the vitnals is very apparent in the lateral half of the levator. So that's the quadrant where I try to search. And like I told you, whatever is that popcorny fat, I retract that in my DEMAR,
In fact,
and everything else I leave with the levator.
I think that is the basic thing. Once you have that pad of fat defined and the septum is open, whenever you retract it, you would see something of a whitish aponeurosis.
You see a little condensation.
It's not really that difficult generally. Just
And I feel like when we look to the lid, the muscles are arranged in two, different position. Obliquus always comes in a horizontal and the levator is like this. It comes in this way. So best way is to feel the tug. You always ask the patient to look up and down, especially in LA. Then you are absolutely sure that yes, you'll see the LPS like just moving down and up. So that is the 100%, and that is the best way. That is what I feel.
So
Yeah,
an
that's
excellent
very true.
presentation by Tajani. I would just add a couple of points which where my experience is somewhat different. Then I don't get good results with 3 or 4 millimeter levator action. I virtually now do only if I have 5 or more, because I get immediate good results. But invariably those patients come back 6 months or 1 year or 2 years later with a return back. I had discussed with Santosh and he said start proline sutures. I did that. It hasn't made a difference. It still happens to me that when I have worked with an action of 3 or 4, they tend to come back in the longer term. You get a good early action if you have a well-defined vitnals and you have taken a bite, done either a vitnal sling or taken a bite close to the vitnal, you will invariably get a good early result. But the delayed results are not very good in my hand, whatever I've tried. Dr. Kim also has presented a large series where she has excellent results with poor levator actions, but they just don't seem to happen to me. So I would probably do a sling if I have anything less than 5. The other thing is about the lash ptosis. I tend to stay in the upper part, and I sometimes find that to symmetrize the tarsal plate show also, I sometimes need to do a little skin muscle resection, and sometimes that, if combined with a little Holtz type suture, takes care of any tendency for lash ptosis, which I feel is largely because you create a disproportion between the two lamini if you're doing a larger resection. If I'm doing a larger resection, I do combine it with a little skin muscle spindle even in children. So those are the only couple of different points. I think thank you very much.
Thank you.
And we'll move to Mukesh, who will tell us about frontalis sling surgery, an excellent surgeon with several innovations to his credit in fascia lata sling surgery. Love to hear him.
Thank you, sir. At the outset, I'm thankful to Dr. Grover and other members of AIOC organizing committee for having me here. And it's a very well designed course actually. I must congratulate Dr. Grover for it also. All right. So when we talk of frontalis sling, the indications we all know, it is a procedure of choice for bilateral severe ptosis and also for unilateral severe ptosis and poor levator action, and I fully agree with Dr. Grover. Initially, I also was doing like the same thing. We were doing levator resection in 3 to 4 millimeter action patients, but now I have also stopped doing this, and I am now doing frontalis sling for these patients because of the simple reason of late droop. So material use, when we talk of frontalis sling, for autologous Mainly it is the fasciolata, though there are some people who use other tendons also like palmaris longus tendon and all, but I think fasciolata remains the gold standard. And for all, for artificial material, I think there is no confusion now with the advent of silicone rod that this is the best material. So there was considered a head-on fight between these two, but nowadays I think it is virtually onslaught of silicone, and people like me and probably Dr. Grover also, like we are very few who are still doing fasciolata in majority of our cases. Like my sling patients, I think 75% of them I still do fasciolata, but I think we are gradually going under minority. So there are some distinct advantage of silicone sling. It is a potential reversible procedure. This is a huge advantage. Wherever you find there may be some scope of reversibility, or some time you may need to reduce the ptosis, reduce the lift in post-operative period, then you obviously should go for silicone sling, like patient with poor bowels and in infants. It is the procedure which gives you least lid lag and legophthalmos. So wherever you are having poor bowels like CPEO, congenital, chronic progressive external ophthalmoplegia, etc., there also you go for this. Then it is readily available material, very short duration of surgery, and almost equal efficacy with fasciolata. Though the complication profile is not nil, but it is acceptable and extremely easy to perform under local anesthesia. So there are various methodology of doing frontalis sling. Largely it is done as Crawford double triangle method or Fox's pentagon method. For silicone rod, we prefer this pentagon only. For fasciolata, there are people who go for double triangle. I personally do Fox's pentagon for fasciolata also. So I'll go for a video of silicone sling. It's a pediatric age group patient. So with over time, what I have learned is that center point should always be marked, that it is not at the center of pupil always. A sweet point where your lift gives you even contour is the central point, and sometime it is 1 millimeter or 2 millimeter lateral to pupil, sometime little medial. So I mark a center point and then 2 points on either side of that central point, around 5 to 5.5 millimeter away. This distance should not be too much, because if you take this distance more than say 10 millimeter, then there will be some bunching up here. So it should not be more than 10 millimeter. Sometime maybe 11 millimeter, but not more than that. So once you have made the pentagon, and I think this point I just forgot to mention, these 2 points should be in line with your canthus, lateral canthus and medial canthus, just above the brow, and central point should be approximately at the center of these 2 points. Then you can place a stay suture. You can make tiny stab incisions also. You can use your RF cautery or any other cautery also for these. So now this is important. Once you have made the central point, you do some undermining underneath the skin, and then you go below it, and below the muscle you make a long track so that your ends of cut end of silicone can be buried there, and there will not be any chance of extrusion. Now I do not cut the needle. Ideally these 2 needles should be used in one eye. You can remove the sleeve from the needle, and you can cut it in 2 halves if you find it is quite long. Then these needles are malleable. You can bend it in an even contour, pass it. So use 2 needles per eye. This is the way it should be done, and use it, start from the tarsus plate. So now whenever you will be passing your needle, it will be in the right direction from downward to upward. If you are using 1 needle per eye, you will have to start from top, then you will be going from above downward, and your thickness will not be appropriate. So ideally you should be above tarsus plate and above levator and below the orbicularis. So this is better ensured if you are doing it from below downward bite. So this is the way I think it is described also, and no point saving on 1/2 of silicone, because these are not so costly also nowadays. So you pass them, come out in the center. These ends should be freely, like movement should be very free here. You should not have any tuck on the skin or subcutaneous tissue there. Then the other advantage of having two needles is that you can thread your sleeve very easily. So by one needle, and then you can thread it, the other part also through the needle only. You need not to make some extra effort to thread your sleeve. Then just tighten it. You can place a non-absorbable suture also and bury these ends into the tunnel which you have already made. So this is the same patient post-operative result. Except in these kind of pediatric cases, I do generally skin muscle excision for silicone sling.
Most
also.
important is the smile post-operative.
Yeah, the child started having a good rapport with me. So I think I'll skip this second video. So some pearl of silicone, never reuse silicone, otherwise there will be more chances of granuloma or infection. Titrate accordingly. Make a long tunnel and combined skin muscle excision in most cases, especially if you are doing it unilaterally in adult. Otherwise, there will be some excess. See, if you do a sling without excision of skin muscle excision, you will have appearance like this. These patients are having good post-operative condition results, but these are not up to the desired level. Now we aim not for good lift, but for good lid crease also, a symmetrical, good crease and good fold is what is required, and that is not possible without the excision of skin muscle lamina. So if you do sling unilaterally, there are some problems. There will be variable lift at different time period, because sometime patient will be using frontalis, sometime he or she will be tired not using frontalis, so lid would be drooped down during that time, so this is a problem. Then there will be unilateral arching, unilateral lid lag and lag ophthalmos. So to avoid these, we try to do bilateral sling also on the healthy side. See the result on unilateral patient. There is this unilateral lid lag which is quite bad. So now we talk about fascia lata. It's a strong material, more physiological, and it scores in tighter lid like blepharophimosis syndrome over silicone hugely. Its elasticity is almost equal to silicone, so almost same lid lag and lag ophthalmos, and it virtually eliminates these problems of silicone. So I'll go for this video, very brief video. You make an incision on the thigh. This is a little modification. We do it almost in the center of lateral part of thigh, so that it gives us obvious advantage of working on either side of this incision, and we can retrieve longer length of fascia lata with this small incision of 2 to 2.5 centimeter. So you reach to the fascia lata. There are some circular connective tissue fibers, and fascia lata fibers are longitudinal. So then you make two parallel nicks into the fascia lata, use a long needle scissor, just glide your scissor with these two and enlarge these two incisions. First undermine it, and then you are not supposed to do any cutting motion, just glide it as sari vendor cuts the saris. Do it from the other side also. Then after doing it, take a curved scissor now, pass it over your fascia lata, just make some up movement and cut the end little blindly, but you will be able to feel the tuck in your other hand. So you can retrieve reasonably good length from one end and do the similar motion in other side also, and you can have a good length. This is around 15-16 centimeter. You require only 10 centimeter of fascia lata. Then you make strips of fascia lata, and then it is done in the same way as silicone was done. Only difference is that we use a right fascia lata needle here. So this is the needle. I'm sorry, yeah, this is the right fascia lata needle which is threaded by the fascia lata. So I'm just running through it. I'm so sorry. Then you pass needle in the pentagon way, same as we have done for facial atta also, for silicone also. So these were the circular fibers of connective tissue which I was talking about, and these are the radial fibers of facial atta which are underneath this. Then while making cut, you try to make your cut along the axis of these longitudinal fibers. If you make your cut not in the same axis, you will be having multiple cut pieces of cut fibers of facial atta, and the strength of these fibers would not be very good. So try to make your nicks in line with the longitudinal axis of these fibers. So then there are certain problems of facial atta. Obviously, you require to do some surgery in the thigh, longer duration, harvestation is a little difficult. So to conclude, silicone rod is the best artificial material available till date. It scores over facial atta in its potential reversibility. It's a simpler procedure, but I still feel facial atta is the gold standard, and it virtually eliminates problems of silicone rod. Though these are in not in great number, but still we do get these problems. In tight lids like blepharophimosis syndrome, facial atta is hugely superior. Though there is some learning curve, it requires general anesthesia. Thank you. Thank you for it.
Thank you, Mukesh, for that excellent presentation, which covered both the procedures very well. Show of hands, how many would prefer fascial atta? How many prefer silastic as the first? And anything else? How many of fascial atta?
Something else.
Okay, so whenever the patient agrees for bilateral, fascial atta. And silicone? Oh yes. Then obviously the silicone is the first choice. Yeah.
What
So-
about frontalis muscle? I think last time me and Feroz, when we were talking, so after discussing with her, so I have started doing some frontalis muscle, and I'm really getting good results. I feel this is also a good option where you use the muscle, you give a blepharoplasty incision, take out the frontalis muscle, and then you suture it to the Ptosis.
Or levator sling, especially for jogging.
No, sir. I've used.
If you are using a fan of frontalis muscle, a fan kind of frontalis muscle,
Yeah, the central
yeah,
part,
yeah,
approximately
central
4
part,
to 5
and you
millimeter.
attach it on the tarsus plate, your direction of pull would be like this, something like this. So what it may do, I don't know in your hand it's doing or not.
No,
So
I don't think she's doing it as a routine.
Not as a routine.
So
I tried
for-
doing 3-4 cases,
in
but
Vietnam
no.
sling, I think
Yeah.
that was the problem. Some people were doing it. So there may be some misdirection of eyelid as a whole, and you may have some kind of entropion of that. I
Fairuz?
don't know.
Fairuz is
mechanism is same, I think, Dr.
Yeah, it is
Mukesh.
the same, Dr.
Yeah.
Mukesh. I've just done 3 cases. I've not got an entropion so far, and good correction, like, you know. Yeah, I think mechanism is the same, Dr. Mukesh, because you're taking the sling also and attaching to the frontalis, so you're anyway going a little bit superficial.
No, because I know in
Okay.
because in Korea,
So
like
it will
they
have to
don't
be
do the
borne
pentagon.
by
Yes,
the
sir.
experience of how many, I mean, once you have
Well,
enough
yeah,
Yes,
cases.
sir.
has
We
to
need
be
to do
number of
more.
cases.
Yeah.
But I'm
Because I
very
think there are a
happy
lot
with
of
the initial
procedures of
cases.
lot of descriptions of Le Mans type procedure also, but nobody is consistently doing it. They are all procedures sporadically get reported,
Yeah,
and then
hesitantly doing, and
Yeah.
I just hesitantly did.
and
3
the results then there are some
Cannot be
undercorrections that they
assessed.
report, and then they finally nobody is consistently
We
doing
need
it
a
the world
larger
over.
series
I
to
don't see
comment.
anybody in the world consistently describing that as his first procedure of choice. So
And
that I
just
think
one
Yes.
comment, sir. I don't know. Sorry, I missed your initial presentation. But how do you kind of tie the silicone horizontally or vertically? How do you finally do it?
I do. It really does not make any difference. The described method is horizontal, but we do it vertically only. And what I feel is once you have made a long tunnel and you are underneath the frontalis muscle as such, then it will not extrude out.
I also do it horizontally. The other thing is, just one comment, sir. I was a very strong propagator of fascia lata, but then after Dr. VP Gupta retired, our hospital was flooded with fascia lata patients. We couldn't manage, and finally we shifted to silicone, and we are doing very well.
You need a generation of followers doing it.
So, no, sir. Now we are very happy and kind of we have given up with the fascia lata.
Results are good with
Very good
Celastic.
results.
I think unilateral fascia lata I never do because they end up with undercorrection. Bilateral, yes, always enjoy fascia lata. Okay, so now we go on to cases of jaw winking, blepharophimosis syndrome and ocular motility restriction. For us with a referral bias, the jaw winking is almost 1/6 of our cases, and the important things to assess in a case of jaw winking are the extent of ptosis, excursion of jaw winking, whether it's significant or not, it is also graded, but if it is more than 2 millimeters, it does require a correction, and associated ocular motility problems. Now the ocular motility problems, as we see, are associated nearly in 50% of the cases of jaw winking, and they need to be taken care of earlier. So as Shilpa said, you need to correct the ptosis, you need to eliminate jaw winking while ensuring maximum possible symmetry. So let's look at the options. Levator resection may be a choice if jaw winking is 2 millimeters or less. Patient's concern is not jaw winking, it is only drooping. So you need larger resections than usual. The classical Crowell Beard text mentions it, and I've found that it is true. And the most important thing is jaw winking is not eliminated. So this is a patient with jaw winking ptosis on the right side, as we can see, and this is following the correction where primary position looks good, but jaw winking takes it above with a little scleral show, though that becomes a little more obvious, and therefore this may not always be a procedure of choice except in very mild cases. So how do you eliminate jaw winking? There are a number of ways described for disabling of levator aponeurosis, but we normally dissect from the tarsus without dissecting on the tarsal surface at all, so that we can put in a sling at the same stage without having to fix it on the tarsal plate, and going up to the horn, going up to the vitnals and cutting both the horns and removing it well. And then first choice procedure is frontalis sling procedure using fascia lata, but unilateral sling was giving us asymmetric lag of thalamus and lid lag, which has been eliminated by bilateral fascia lata sling surgery. Initially, we did levator excision of the involved side with bilateral fascia lata sling surgery. This is a patient with jaw winking ptosis, as you can see, and this is following unilateral levator excision on this side with bilateral fascia lata sling. But the problem is that the jaw winking is eliminated, but there is this undercorrection and asymmetry of brow action. Now this does not get eliminated with a unilateral fascia lata sling. So this is what we are doing now, bilateral levator excision with bilateral fascia lata sling surgery in most cases except the occasional one. So this is the procedure where I do a modified Crawford technique with the incisions on the lid marked according to the position of the fold that we want. I also mark the lid crease incision and give a 1-inch incision, go up to the fascia lata, dissect with the long scissors, create a plane between the vastus lateralis muscle and the fascia and cut it with the long scissors, remove redundant tissue, divide into 4 strips, close the wound, and then give our 4 incisions rather than 3, which was the original Crawford. Go through the skin orbicularis, open up the orbital septum to expose the preaponeurotic pad of fat, expose the levator aponeurosis, dissect between the levator aponeurosis and the conjunctiva mullus without going on to dissect onto the tarsal surface. And then once this dissection is complete, you need to do a good dissection, and you need to cut the horns well here, which we don't do in most cases of levator now. And you excise right up to the vitrinals, and then you do it on the other side as well, the normal side. Do a good excision, create the appropriate planes for passage of the fascia lata, do a dissection to position the fascia lata finally, and then we use a hemostat to pass between the two eyelid incisions on the outer side, then use a right fascia lata needle to pass it to the brow incisions in the double triangle fashion on the two sides to complete a double triangle, tie the two sides to assess the contour, assess the correction, then double the knots, then secure them with a vical. Then I invariably, nearly in all fascia lata, in all sling cases, would do a skin muscle excision to remove all redundancy, and then take it with the right needle to the central incision. Make sure that you bury all the knots very well in the depth to avoid any granulomas. Just close the skin. I don't make them as lid fold forming sutures, and then put in your frost sutures. So Marcus gun ptosis, bilateral ones have been the most satisfactory cases, where we get a very good symmetry and a good correction, and the jaw winking can be abolished nearly in all cases. 97-98% would have good elimination. For the blepharophimosis syndrome, we all are familiar with all the components of it. We know the inverse epicanthal fold, horizontal decrease in size, vertical decrease in size, and flattened supraorbital ridges, lateral ectropion, so on. And we know the gene for this to happen, an autosomal dominant transmission common in several parts of the country. As you'll see in the subsequent examples, all severe cases I would do a two-stage procedure, and for the relatively less severe cases I would do a single-stage procedure. So the first stage I would do a Y2V plasty or a double Z plasty Mastades. This I rarely do now. I largely do Y2V. I also did some C plasties earlier. Mastade was strongly opposed to them. So Mastade was very happy to see one of mine where I showed that there is a bad scar after C. He said, I want that slide. Mastade was very happy to see that because he was strongly opposed to a C incision. Okay, so then we do a transnasal wiring in all severe cases. In other cases, we would do a good tucking in milder cases only, but that's unusual. Most cases do require transnasal wiring, so this is how we do it. After you made the measurements to make your markings, you mark the central position, you mark the double Z plasty according to the measurements that you have made, because you want to shift your medial canthus to this position. So that is your objective. That's how you make the measurements of this. Expose the area of the lacrimal fossa, excise remove the bone, and this is in line with the medial canthal ligament, so that this is where you're going to shift your medial canthal tissue. Then we use a hypodermic needle to pass by railroading past our stainless steel wires. This is a relatively thick one. Normally I use much thinner ones now, generally around 26 or 28 stainless steel wires. And once there is a double passage, and then you pass it across with the right needle, or the oldest right needle which is not doing very well, you can use that, and then you take it to the other side, again use the same technique to pass it through the medial palpebral ligament on the other side, relatively medially, and you need to debulk some tissue at the medial canthus in order to move the medial palpebral ligament and the medial canthal tissue into the nasal cavity really, actually. And so this is a double passage. These thicker needles are, thicker wires are much more difficult to handle. So if you use a thinner one, it is much easier. And then you finally rotate it and give multiple rotations and make sure that the knot goes into the nasal cavity. It's not exposed anywhere outside till you get the right correction, and then you can get a really deep position which is sustained. So this is a stage 1 surgery. The important thing to see is the kind of depth that you can get, which you can't get with any other procedure, which is sustained. And second stage procedure can then be done to get a good correction. Of course, the kind of correction you get is limited by the anatomical structures, and you can't get it like the other cases. And this is a single stage procedure, relatively milder case where we've done a YV plasty with the tucking of the medial palpebral ligament, and this is how you can get good results. Finally, a little bit about the ocular motility disorders. As you see, it is ocular motility restrictions are almost 1/4 to 1/3 of all cases of congenital ptosis, and in jaw winking it is nearly 50% of the cases, half of them superior rectus and half of them MED. And now the most common is superior rectus underaction, but you may get monoocular elevation defects quite commonly, or congenital third nerve palsy may be the association, or horizontal deviations, or congenital fibrosis syndrome. So the management would change accordingly, and the ocular motility problems always need to be tackled before ptosis correction to ensure a proper assessment of ptosis, adequate Bell's phenomenon, both reasons. And forced duction test is essential before you take a decision on what you're going to do. Based on that, you choose your surgical procedure either as naps or inferior rectus recession, which may be combined in 2 sittings with a naps procedure. So examples of congenital third nerve palsy, which has an associated hypotropia and exotropia, which was stage 1 corrected for the squint, which gave a reasonably good upward rotation and Bell's, and in stage 2 a fascia lata sling was done. So we could get a reasonably good result with cornea being safe. And the final example of congenital ptosis with hypotropia with jaw winking, which was associated with a superior rectus underaction, as we can see here, and after inferior rectus recession, the position in the primary position improved, upward rotation improved, and we could do a bilateral levator excision with bilateral fascia lata sling surgery. This is in primary position, down and closure. So you can get a good elimination of jaw winking and a good position of the eyeballs with a good correction of ptosis with this procedure. So it is possible to tackle these cases with appropriate selection of the procedure. So any questions?
So my one observation I wanted to ask whether you also have had patients where we have had Marcus-Gunn jaw winging and we do LPS excision, the recovery of Bell's is pretty much delayed. Is that your observation also? And I kind of have started putting BCL in all these patients because you send the patients back and the recovery of Bell's was, and we had patients with keratitis post-op, so exposure keratitis. So I don't know, we have lots of actually Marcus-Gunn jaw winging, so maybe we are over estimating the, but I don't know.
Maybe we can reduce the dissection towards the phonics.
Only I just excise the central part. I don't even go upwards. Still, I have observed that this is my observation. This may be just something which is happening with Marcus-Gunn. I know the others have also observed this. Vis-a-vis your other patients, these patients would have delayed recovery of Bell's. Maybe you can start.
Sometimes I get inverse Bell's.
Inverse is very common, but
this delayed, Bell's, I have not come across.
I haven't so far noticed. Maybe I'll give more attention to that
Maybe.
now. So we can go to the final talk now by Dr. Shalu on the complications, the most difficult part.
Can you hear me? Yeah, so we all know that ptosis surgery is the most rewarding surgery, both to the patient as well as the surgeon, but we do encounter complications in our, we have encountered in our life, and we do see a complication in the hands of best of the hands, and sometimes even if we follow the best guidelines, we may have the surprises, and as each eye and each tissue behaves differently. So here we are, I'm here to just negotiate this maze, that why and how, why these complications occur and how we can tackle them. The intrinsic complications which we all know are present with the ptosis surgery is the leg of ophthalmos and lid lag. So we need to counsel the patients and the family pre-operatively, and we have to give them lubricants as well as the antibiotics in the early post-op periods. However, the avoidable complications we do encounter are the undercorrection, overcorrection, exposure keratopathy in some of these cases, lid crease abnormalities, eyelid contour abnormalities, conjunctival fornix prolapse in the larger resections, or granuloma formation and infection in the case of synthetic materials. So coming to the undercorrection, it can be due to the improper choice of the procedure. As we have already discussed all the procedures which are commonly performed, like in we have a levator action of 9 or so millimeter, and if we have performed a fascicular servate, the patient may land up with the undercorrection, or if we have not done a proper levator resection, there can be a post-op slippage of sutures or loosening of the knots in the post-op periods. So coming to the management of undercorrection, if we feel there is a lot of edema post-operatively, we should observe the patient, and in case there is a gross undercorrection and there is not much of the edema in early post-op period, we can go for early readjustment of the sutures. However, in all late post-op phase patients who present too late to us, or we have late residual ptosis, then each case should be evaluated as a primary case and then decide what procedure to be chosen. I like just to stress on this point. If the patient has already undergone fascicular servate surgery or tarsoconjunctivulectomy, what we say, then we should be not re-go for the fascicular servate, as we have very short tarsus in our Indian population. So we should be cautious in these cases and should go for levator surgery. There are some of the examples. The patient had undercorrection following the fascicular servate surgery. However, this patient had a phenylephrine test positive when I did it preoperatively, and had a good levator action, but landed with the undercorrection. So I have performed the levator resection in these cases and showed a good desirable result. This is showing the same patient in the up gaze and a down gaze. This is a child who presented about 9 months post-operatively following the previous levator surgery. Had a levator resection of had a levator action of 8 millimeter, but landed with the undercorrection. So the resurgery was done and showed a good result. This is in the up gaze, but had the more lid lag in the down gaze. So these need to be explained to the patient when we are performing a repeat levator section. The difficulties which we have in these repeat surgeries, there will be a less effective local anesthesia if we are, and so we have to infiltrate them with usually a 1:180,000 anesthesia, xylocaine ADR I prefer. They have more scarring, dissection of the plane will be difficult, and there may be more chances of bleeding, and we need to explain to the family there will be more lid lag and leg ophthalmos, and due to the larger resection, they may land up with fornix prolapse. So we should all keep in our mind before taking up the patient for the levator resurgery. This is another patient who had an undercorrection following the previous skin approach levator resection, had a levator action of 4 millimeter, So in this, the frontalis sling surgery was preferred and was taken up in the repeat surgery. This showed a good correction. This is an up gaze and a down gaze of the same patient. I like to stress upon the frontalis sling surgery, the patient who had a poor levator action, and so the frontalis sling was the choice of procedure and was carried out. And we usually aim for a slight overcorrection in these cases, but however late post-op, they do end up with a slight undercorrection. So if the patient is not happy with the correction, in around 4 weeks or so, when the swelling has subsided, we can make a small nick in the forehead incision and can tighten the sling if we want. Overcorrection is uncommon with the congenital ptosis and usually seen in the acquired cases. However, the immediate treatment goal is in these cases is to protect the cornea. So slight overcorrection about a millimeter or so can be managed with the massage, where we put a firm pressure and pull the lid downwards. So it helps in the stretching of the internal wound. And however, if we have a more overcorrection, then we have to take up the patient early, and we may use the stump which have left behind. We can recess the levator with that, or we have to go for the hangback sutures. This is an example who had acquired ptosis and landed with the overcorrection, but fortunately responded to the massage. However, this is very, we have surprises. This is a child who behaved like, had a levator action of about 8 millimeter or 9 millimeter, I don't remember exactly, but had landed with the overcorrection and has to taken up for the early surgery. So we do have surprise in our experience, and so we need to keep everything in our mind and plan the surgery accordingly. For overcorrection in the late phases, we have to follow in milder cases, we can go for the mullerectomy. And if the overcorrection is of 3 to 4 millimeter, we can go for levator recession graded with or without mullerectomy. And in severe cases, we have to go for spacer grafts. So this is a mullerectomy for mild overcorrection. The graded levator resection can be done through the posterior approach or the anterior approach. And if under local anesthesia, we can ask the patient to sit up and assess the. We have to overcorrect. We have to put the lid downward, and we expect that the lid may rise within the post-op period. So we have to do the more recession in these cases. This is a patient who presented with the acquired case, who presented with the overcorrection, had to go for a levator recession with scleral grafting, and this is the scleral patch graft was placed, and this is about double the size of the retraction which we have, so we have to put double the size of the scleral patch graft. This is a post-op 3 weeks period, and showed a good correction. This is the improved lid closure. The exposure keratopathy is seen in may occur in all kind of after ptosis surgery. So we have to be sure, and we have to give them excessive lubricants and the ointments, and do the lid taping at night. So this is the post-treatment. Lid crease abnormality can occur if we have not removed the anterior lamella properly. This is the overhanging lid skin. So the skin excision with lid flow creation is performed. Lid contour abnormalities can vary from the peaking of the eyelids to the residual ptosis or retraction, and need to be managed accordingly. So the example is in the milder cases, we can do the massage and stretching, and they can improve. However, if there is a significant notching, as in the previous case, we have to do the readjustment because this is due to the improper placement of the suture. Entropion, we have already been discussed also previously. It is due to the discrepancy between the two lamella, and lash entropion do occur in some of these cases because of the anterior lamellar strippage, and there is a loose adhesion between the orbicularis, tarsus, and the levator. So in these cases, we have to do the tarsus, clear the tarsus anteriorly up to the lash follicle, and can pass the suture through the skin orbicularis, levator, and the skin again, or do separately the tarsus and the orbicularis suturing and do the skin closure again. This is another example of showing the undercorrection with entropion and excess skin following the levator resection. So the skin muscle excision with suture readjustment was carried out and showed the improved lid crease formation and the symmetrical results. There are certain complications specific to each procedure. Like we have already discussed, the suture keratopathy can occur in fascicular cervix. So we have to externalize the suture in these cases and have to test the dry eyes. So we have to do the Schirmer's test preoperatively to avoid these cases. The fornix forming prolapse can occur in levator surgery if we are especially performing the larger resection, and then we have to reposit them, or in some cases we have to excise the prolapse fornix. The granuloma formation and infection do occur as there is a synthetic material is being used, so we need to remove them if there is a granuloma formation in these cases. This is an example of a granuloma formation after the sling material. So complications do occur after surgery, but we need to do the proper assessment, and we can avoid these complications if we have done a proper evaluation and management. And the best thing is that if the complication has occurred, we should know how to manage them. Thank you.
Thank you, Dr. Shalu, for an excellent collection and excellent presentation. Any comments on, let's say, what does Mukesh do when there is an undercorrection in an acquired ptosis in the early, first, second, third day? Acquired ptosis, aponeurotic ptosis, levator action, say around 10, 12.
Yeah, that's what I actually aim for, and I do not call it undercorrection. That's the desired correction in most cases, because most of them they tend to lift up.
If it is a significant undercorrection,
yeah, if it is a significant
on the first, second post-op day in a acquired aponeurotic ptosis, let's say.
Yeah, if undercorrection is significant, then I do not wait beyond 7 days. My strategy is to call patient at the suture removal time and just see, because by that time the lid edema also goes away, most of that, and some amount of hematoma, that also goes away. And if undercorrection is significant by that time, and we can judge it with our judgment that this lid will not lift up later on, then I go at that time only. I take up the patient and do the.
Yeah, I think I agree. This is what I do, but I add steroids if it appears to me on the first day.
Correct.
That it is, so I add oral steroids and assess at the end of 1 week. Prepare patient mentally to say that I'll assess at 1 week, and if need be, I'll do some adjustment of the position, which is technically true. It may be like a resurgery. But then I do it if it is grossly overcorrected also in an acquired ptosis, I would do the same. But I think gradually those numbers have reduced as I've got a little more experience, but still those cases do occasionally occur. Earlier I used to get them very, very frequently. I mean, it was very difficult to judge which case with elevator action of 12 will behave in what way, but gradually intraoperative assessments have made a huge difference. You can pick up intraoperatively.
One other thing I think which need to be highlighted is that initially, at least I used to advance levator aponeurosis a little bit more on the tarsus plate, anterior surface of tarsus, while passing suture on the tarsus. Sometimes it contributes to the fornix prolapse, which we do get after this surgery. And as a treatment modality also, I think in most cases of fornix prolapse, now I do not pass fornix formation suture to correct fornix prolapse. What I do is I go from the incision side, I just recess the levator aponeurosis, take some bite of prolapsed conjunctiva from inner surface while reattaching the levator. So tarsus, some bite from the prolapsed part of the conjunctiva and fornix, and the levator stump again while recessing it. So that corrects prolapse beautifully, and that avoid passing fornix formation suture and leaving them for 3 weeks or so.
No, but if you recess the levator, then does the undercorrection sets up?
Nearly always with fornix prolapse you have some overcorrection. If you are having undercorrection with fornix prolapse, then obviously it's a case of excessive dissection and you need to do it that way. But nearly always you will have overcorrection. Whatever picture I saw of fornix prolapse in, I think all those cases they had overcorrection.
Yes.
What time you take? At what time you do the recession? After how many weeks?
Everything at suture removal time. So as Dr. Grover has said, you mentally prepare patient that we may do something when you come back for your suture removal, and that's the ideal time to do these things.
But fornix prolapse I've usually seen in congenital ptosis, but not in acquired ptosis.
If you are doing plication in acquired ptosis, you may see fornix prolapse there also. And the same thing happens in plication. If you are doing plication, then it is of paramount importance not to pass your suture in the middle of tarsus. You have to be at the superior part of tarsus only. Never do advancement on the tarsus while doing plication.
I know of no indication where I do advancement except very rare cases. So I have virtually never done it. So I stay in the upper third of the tarsus. That is one. Okay. Yes, Tarjini, after that.
So when you take the bite of the conjunctiva for fornix prolapse, does that full thickness bite produce any sort of corneal?
It's not full thickness. Carefully you have to take only the inner fibers into it. You obviously would not want to have corneal problem.
The other thing that I wanted to say is that those maximal, supramaximal resections I have virtually given up. So that is the reason I think I haven't seen fornix prolapses of late. There was a time when we would, for bad cases like 3 millimeters, 4 millimeters, keep dissecting and cut horns and go up and put the sutures. Virtually given up now.
So sometimes for re-surgeries, when the previous LPS resection has already been done and you then go ahead and do more dissection and there's a lot of fibrosis, I have had sometimes fornix.
Again, in those cases, I've realized even with an apparent levator action of 7, 6, 7, I now go in for sling in those, and I rather than a repeat resection. I used to do most cases as repeat resections, but now I've come to realize that aesthetically I end up giving them a better result with a celastic sling.
I had a lot of problem with these patients with blepharochalasis when they come back with kind of epineuritic ptosis and you go back and operate them. They are so unpredictable. Their skin is so parchment like, and then you feel like excising it, and I've had lid retractions after that, and now I'm really kind of apprehensive when I operate those cases. So again, the epineuritic kind of ptosis is very unpredictable, and how much skin would you excise in those patients? The skin is very lax and epineuritic. I think when all of you must have done that. So what would be your nomogram to how much to excise? Because on table it looks like, yes, this is what is coming, but then post-op you have.
One most important, that if time has elapsed since the episodes kept occurring and you're doing it, then you are much safer and you get better results. Your skin is better and you get better results. If they've had recent episodes and marriage is approaching and something has to be done, then you have to tell them that the results could be dicey, there could be recurrence, but you would do it to make them good at that time.
Yeah, a rough thing to prevent this, which you are saying, I have also had encountered in few of the cases, because there is a obvious tendency to excise it more. Leave always 25 millimeter of the lid skin as anterior lamina. So if you have lesser than that, there may be chances of more shortening of skin than it is needed.
25 becomes too rich. I would leave it at 20.
Yeah, because usually you don't have that much.
But have you tried pinch test?
I did. Usually that's the way you do it. You do the pinch test, but you do see the post-operative results. When you do it for the congenital ptosis, everything works. But when you're doing for this, yes.
Just one small point if I can make there. So I go by what is the intra-op position of the levator. If it is a disinsertion of the levator, which is common in blepharochalasis because of the constant expansion and contraction, then I only reinsert and see what happens to the eyelid height. I don't resect the levator anymore. Sometimes with these disinsertions, you will see that the aponeurosis is condensed it's shorter in length. It's not the 18 or 20 millimeter that we learn the length to be. So that itself acts as a resection, and in those situations you're more likely to see an overcorrection post-operatively. If it is a dehiscence, then I resect. But if it is a disinsertion, I only reattach.
Yeah, and you have to be very conservative, because on the table tells you that even if you take it through the first visible point of the aponeurosis, you sometimes are seeing a gross overcorrection. So in those, you are really really need to unfold that part of the last part of the aponeurosis, and even then, even with the unfolded proximal most part, you sometimes tend to need to take a bite before shorter than that. Yeah, so that essentially, that's what I do when I take a bite through the part short of the aponeurosis, through that tissue, it essentially becomes a hangback.
Sir, one of my question is, in case of a LPS dehiscence or disinsertion, are you prefer a same day surgery both eye or in a different day?
I would prefer a same day surgery for both the eyes. It's easier to create a symmetry, and also otherwise, as we were just discussing, herrings can be very troublesome.
Yes.
You correct one eye, the other eye looks good, it starts looking bad the next day. And then the patient, unless he's been warned, unless he has chosen to have a unilateral surgery, he will curse you quite lovingly.
Then, sir, if the patient wants, there is one eye 80% dehiscence, one eye 60% dehiscence. If patient only allowed in one eye at a time, which eye will prefer? That 60%
Severer eye.
Yeah.
Always.
But severer eye, then chances of overcorrection is more. Initially, it may looks like overcorrection, but once you can do the other eye, then
you can tell them. You can tell them that also, that the other lid will come down.
To counteract that overcorrection.
Yeah, that sometimes also happens. You have to tell them that it will come down. I think last comment, and then we...
Just a closing comment that in Ptosis there's no right, no wrong, no good, no bad. It's all individual, because everybody's results are individualistic.
Are equally bad.
Yes.
Or equally good. It's a way of looking at it. So I think we all need to keep learning. That's the baseline, and you can't leave without a photograph. And thank you for the audience. The audience has been wonderful to have stuck with us. Thank you. Photograph.